Good morning, everyone, and welcome to another fantastic brunch session in our healthcare maintenance and IBD series. This series is supported by educational grants from Janssen, Pfizer, and Takeda. I'm Dr. Aline Charabaty. I'm an Assistant Clinical Director at the Johns Hopkins School of Medicine, Division of Gastroenterology, and I'm the founder of Monday Night IBD. And I'm joined today by my very good friend and colleague, Dr. Adjoa, Anyane-Yeboa. She's instructor of medicine at Mass General. Adjoa, welcome. Thank you for being here this morning.
Thank you so much for having me. I'm super excited to be here.
Me too. I think we have a great conversation ahead. Before we start, our faculty disclosures are on the screen. IBD is a group of challenging disease. Our patients have many challenges in terms of accessing quality care, continuity of care, having comprehensive and multidisciplinary care. And unfortunately, some of our population in this country have increased burden when it comes to accessing quality of care and multidisciplinary care and in managing their inflammatory bowel disease. So I wanted us to talk today about healthcare disparities in IBD and social determinant of health in IBD. So before we get into the meat of the conversation, can you remind us what are social determinants of health?
Absolutely. So I think this is a really important discussion. I think it's important to note that the social determinants often underlie health disparities. So the social determinants of health are defined as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. So just to go on with the definition, so these forces and systems include economic policies and systems, development agendas, social policies, and political systems. So it's really important to note that these social determinants are kind of built into our society. And so if we think about, for instance, the policy of redlining, so that's a great example of how a social determinant and how policy can impact health outcomes. So for the federal government, through the Federal Housing Administration, used color codes to identify areas that were off limits for providing mortgage loans, particularly to communities of color. So today, these same neighborhoods have poor funding and upkeep from local and national governments. They might have poorly funded schools, limited economic opportunity, low-wage jobs, which all can lead to poor health outcomes downstream. So it's really important to think about these social determinants when we think about disparities in our patients.
This is so important to realize that where our patients live actually determine how healthy they're going to be and how they're going to access care and quality of care. And it's at so many levels, our system, our government level, and our community level and socioeconomic. So it's a very intricate system. And I can imagine also if you are in neighborhood that have less access to care, you're also in neighborhood that have less access to healthy food, have less access to appropriate education, or even a gastroenterologist. I mean, I imagine some of those communities maybe have barely access to the primary services in terms of health services, left alone, an IBD specialist or a gastroenterologist.
Absolutely. And that's exactly what you said. So the social determinants, there's actually several categories, many of which you kind of touched on already. So you think about whether people have access to gainful employment where they actually have access to coverage, where they have employer-sponsored coverage. You think about where people live, do they have green space, can they exercise? Is there access to education? Do they live in a food desert? Do they have access to quality providers or quality providers that speak their language, high quality care? I think all of this really is important when we think about healthcare and health disparities, because these upstream social determinants can lead to poor health outcomes downstream. And oftentimes people say that your zip code is one of the strongest predictors of your health. And that is so accurate, because where you live often can dictate how long you will live, your life expectancy, and how you will fare in a whole host of different diseases. So it's really important that we think about this.
Absolutely. I mean, I'm thinking about, patient living with IBD, so needing to take time off work to come and see the physician. So if you're living in an area where the jobs that are available are, paycheck to paycheck or, daily work, taking half a day to visit your physician or get a colonoscopy can really be very burdensome, or maybe there's no daycare available for somebody to watch your kids. Transportation. I mean, if you don't have a GI in your neighborhood and you have to drive 2 hours and you don't have access to adequate transportation, let alone the whole world about, biologic and drug monitoring, etc. All that we think about, when we think about providing and maintaining our patients with IBD healthy and providing quality of care, I can imagine how these conditions really amplify the burdens and put barriers to accessing these kind of quality care. So Adjoa, how do social determinants of health impact the treatment, the access to care, the treatment, and the outcome of our patients with IBD? What do we know about this?
Yeah, so you've touched on some of this a little bit, but I really like to think about these upstream determinants like racism, zip code, poverty, policies, and then these upstream determinants then impact midstream determinants, like whether people are facing financial toxicity, whether they don't have, whether they work a low-paying job, whether they have food insecurity, whether they have psychosocial stressors, whether they're facing a disproportionate share of stress, whether they have poor social support. All of these factors then can lead to downstream poor health outcomes in IBD, like more flares, or delayed diagnosis, worse disease severity, maybe using corticosteroids more because you can't, get into your infusion center regularly because it's not open at the hours that you need to go. Suboptimal medical management, more ED visits, all of these factors can really lead to worse outcomes in IBD. And we've seen this in research as well. There's been studies that looked at some of these social determinants. For instance, there was a study that looked at food insecurity and outcomes in IBD. And in this study, they found that patients who had more severe food insecurity or worse food insecurity had more financial hardships from medical bills, they had more financial distress, they had more cost-related non-adherence. So these social determinants and these social factors really impact our patients. And I think it's really important for us as providers to be able to have these conversations with our patients so we can understand what people are going through and understand the barriers that they're facing to optimal management of their IBD.
Absolutely. I think, everybody, people are proud and some people might not come and tell you, I'm having trouble with my copay, I'm having trouble transportation. And I fear that sometimes we label some patient as being non-compliant or no-show or, not following instructions and then dropping off our system, being discharged from a practice and not realizing that the reason they're not here or they're not taking their medication are multiple, anywhere from accessing care, having good insurance, having, good family support, having transportation, all of these things that have to be in some kind of ideal situation and able to achieve.
Oftentimes we put unfortunately, the burden on the patient and the blame on the patient when it's not necessarily the patient, but it's the system and the society that the patient is living in. And so oftentimes we need to look at the bigger picture and the root of the problem rather than putting all of this blame on the patient because it's not fair.
Thank you. I mean, I think you're highlighting very well how social determinant of health and health disparity are connected, and the many barriers a patient with IBD from certain zip codes or racial and ethnic minority are facing, and how this really has to be addressed from a system point of view. But until the whole system change, until we get to a better world, what can we do as clinician, physician in our practice, in our institution, in our community to address these health disparities? When we see them, when we recognize them, what can we do for our patients?
I think number one, just generally, we need to diversify our workforce, our healthcare workforce and our GI workforce. So we know that individuals from underrepresented groups are more likely to do research in disparities that can get us answers to some of these questions and solutions, but are also more likely to work in areas where they can take care of diverse patient populations. Our current GI workforce does not represent the diversity that we see in our general society, and we really need to work towards that. So that's just an overarching thing that we need to work on. At the practice level, we really need to be creative. We need to be creative about finding ways to address barriers for patients. I think it really just starts by asking questions to patients what they're facing, if they're not showing up to appointments or if they're missing their infusions, and asking, what might be going on versus you have to take your medicine and you have to show up, but really get to the root of the problem. And then not only that, but to work with community organizations and to partner with community groups in order to be able to deliver solutions to patients. Oftentimes we see patients very regularly. And so if we identify a problem, we should also be able to connect them to appropriate resources as well. And then another thing I think that we should be doing as healthcare providers is we really need to meet patients where they are. So we know that, for instance, community health centers take care of a large share of vulnerable patients, but community health center patients are specifically facing barriers to specialty care. And so I think it's really important as providers, as GI providers, to meet patients where they are. Oftentimes we work in the big academic health center, not all patients can access that, so doing a few days a week or a few days a month in a health center might increase access for patients who might not be able to make it to the large academic center. I actually do one day a month at a local health center in Boston for that exact reason. And I think also as healthcare providers and as practices, we really need to be involved in policy. We really need to be advocates for our patients, advocates for, what's going on in the political arena. We need to make sure that we are fighting for equity in terms of the social determinants. We need to think about policy like the Safe Step Act and make sure that all patients have access to the medications that they need and the therapies that they need. And we really need to push for more funding for disparities research, because we know that research in health disparities is often underfunded. Minority researchers are often under-awarded and underfunded, and we really need to do better if we want to move forward.
This is amazing. I think, the main message I get here is that we have to be advocate for our patient, right? So we have to discuss with them what is going on in their life, ask them what are the barriers that they're facing. They might not bring it up. We have to advocate for our, in the field of GI, to be more inclusive and increase diversity in GI. We have to advocate at the policy levels. We have to advocate in our community by reaching out to the patient where they are. And we have to make sure that our patients are included in clinical trials and in studies, and really have a focus on how IBD affect patients from all background, including the patients that are often excluded and not have access. Like you said, I'm just thinking, if you don't have access to an academic center, you cannot be enrolled in a trial, right? For example. And I know that there's a lot of fears and barriers in terms of research based on the history of the country. And we really need to, like you said, reach the patient where they are, not only on the community, but at their language, at the culture. And I think, when physician and patient advocate who look like patient are talking to the patient, that is so impactful. And so I think it's really important to increase diversity at all fronts, right? For our patient advocate, for our clinician, for our healthcare system. And I agree with you. This needs to be addressed, from clinic to community to institution to policies.
Yes, absolutely. It's so important to move the needle forward, and not just to identify disparities, but also to identify solutions. So a lot of the work that I'm doing now is, yes, understanding, but understanding from a patient perspective, surveying patients, Black and Brown patients, partnering with community organizations and patient organizations to really hear from the patients what the barriers are, but from that to develop and identify solutions to lead to change. And so some of the work I'm doing right now is involved in that. I'm doing work kind of on the more national level to understand what IBD even looks like in Black patients, and what the course is like, and what the incidence is, and kind of how things look like. So that's one thing I'm working on as well. But really working to not just identify the problem, but identify solutions. I think historically in disparities research, we just wanted to, figure out what the differences were, right? A disparity is a difference, but we need to move past that to the next stage and really figuring out what are we going to do? What are we going to do to move the needle forward? And what are we going to do to advance equity and make sure that every single patient has what they need to be as healthy as possible? Some of the work that I'm also doing is partnering with community health centers in Boston. So I'm doing work in partnership with some of the local community health centers, just to make sure that every patient has the opportunity to be as healthy as possible.
That is amazing. Really attacking the problem from all sides, but you're doing it so amazingly well. It's actually, I love that you are asking the patient what the problem is. It's easy to come and say, well, I think the problem is that, but really the patient experience and how they are living this disease, and what are the barriers they're having, that's so important. And I agree, this has to be a partnership with all the stakeholders, right? The patient, the GI societies, the institutions, the policymakers, the patient advocacy group, etc. And it's only like this that can really highlight the issue, but also do something about it. Like you said, numbers and just quoting data is not enough. It's time to do something about it. And I do believe the time is now. And I think thanks to people like you working on this, and having the drive to be part of the change and to be the change, I see that, there's such a need for things to change. And thanks to people like you on the physician side and the scientific side, and then thanks to patient advocate, I really feel this is the right time. And I feel this collaboration actually between patient and physician is key to drive things. And in some weird way, I think the social media world that we got thrown in with COVID has really helped bringing patient and advocate together and shedding light on different perspective and creating this collaboration that can only bring in change moving forward. So I'm really excited to know what you're doing, and it's really exciting to see.
Thank you. Thank you so much. And I completely agree. I think social media has really made it possible to connect with people. COVID, Zoom, we can work with people across the country now. So it's easier. Change is hard, but it's easier to do it together. And I think it's really important what you just said.
Absolutely. Adjoa, thank you so much for joining me today. This was a fantastic conversation. I mean, I'm leaving with, this is the type of conversation where you often feel frustrated and so often angry that, this is not fair. It's not fair that where you live determine, your quality of life and your health, etc. It's just not fair that where you are born is going to determine that. And we do see the struggles in our patients with IBD even more amplified in some communities. So often this subject brings like anger and frustration, but I'm leaving with a lot of hope and excitement because I could see that, we're like real steps are being implemented and true research that we can have, we can act upon is happening. So I'm leaving excited and happy and hopeful. So for those that joined us, thank you so much for joining us. Please don't forget to check out our disparity and social determinant of health in IBD tutorial that were posted under Monday Night IBD handle. Make sure you claim your CME credits by completing the post-test and evaluation. And we'll keep seeing you during these brunch, and enjoy the conversation with the experts in the field and good friends. Thank you. Have a great day.